All right, we're connecting now. Awesome. We're now live. Okay. Hi, everyone. Thanks for joining us today. I'm Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation. And today I'm so excited to have Dr. Stanietzky. He's a radiologist in the Houston area, and he's affiliated with MD Anderson Cancer Center. Thank you so much, Doctor. How are you today?
Thank you. Doing great. Great. How are yourself?
Doing well. Sorry for the brief delay, everybody. We had some difficulties, but we're ready now. So whenever you're ready, Doctor, go ahead.
Thank you very much. As Scott mentioned, today we'll be talking about imaging of renal cancer. I'm a radiologist in Houston at MD Anderson. My email is here. So if anybody has any questions afterwards, or you feel free to ask after the talk, or you think of things later, feel free to email me. I'd be happy to answer any questions. Renal cancer, just sort of a brief topic. So renal masses there's benign and malignant renal masses. And as radiologists, this is our job to try and distinguish between these so that we prevent people from having unnecessary surgeries, and to also help people understand what they might have. And our doctors that refer the patients to us rely on us for that. This is just not a comprehensive list, but just to show you how long the list is. So renal cell carcinoma is the one that we're probably most familiar with, the renal cancer. And the ones that are cancerous lesions in the kidneys are bolded here. So transitional cell carcinoma is another, and renal lymphoma is another. But there's benign lesions in the kidneys, such as angiomyolipomas, renal abscesses from infection, oncocytoma, renal leiomyomas. These are benign lesions, benign tumors. And then something called the multilocular cystic nephroma, which is a benign multilobulated cystic mass. So I'll go through some of these and the imaging features, and it may get a little technical, some of the imaging and that sort of thing. But if there's any questions afterwards, I'm happy to discuss. So we'll start with renal cell carcinoma. So you can see this is a kidney that's been taken out, and there's a mass in the kidney, a solid mass, and this was found to be a renal cell carcinoma. The kidney is obviously cut in half here. So just a little bit of background that relates to imaging with renal cell carcinoma. This is the incidence of renal cell carcinoma, the mortality from renal cell carcinoma, and the metastatic incidence from renal cell carcinoma. So what you can see is around the late 70s, early 80s, the incidence of renal cell carcinoma increased progressively, and then it sort of leveled off around late 2000s, 2010 or so. And this is almost a doubling of the incidence. And people were confused at first as to why this is happening. Why are we seeing so much more of this? And what they realized was around this time, we started doing a lot more imaging, ultrasound, CT, MRI, and we were detecting a lot of these cancers incidentally. In other words, someone was coming in for a completely different process, had a scan, and a mass was found in their kidney. And what we found over time is several of these masses were probably present at this time, but were not detected, and patients had other things. Eventually mortality occurred from other causes as they got older. So a lot of these renal cell carcinomas were eventually found not to be very aggressive, which is why the mortality, in fact, the mortality trailed off a little bit, even though the population is aging over time, and the metastatic incidence trailed off over time because we have better treatments. So a lot of renal cell carcinomas that are detected today are detected incidentally. And the leveling off was around here because imaging at this point became sort of leveled off, the use of imaging. So just that's something to keep in mind. A lot of renal cell carcinomas are seen incidentally. So as far as imaging for these renal cell carcinoma, it's 80 to 90% of the malignancies in adults. So the most common by far. The peak age is 55 years old. And there's some predispositions, people who have von Hippel-Lindau disease, which is a genetic disease, acquired cystic disease, people on dialysis have a higher predisposition. And then smoking and other sorts of things. Tuberous sclerosis possibly has a higher incidence. And there's familial forms with chromosomal translocations as well. So these can run in families. And then when we talk about renal cell carcinoma, it's not one entity. There's actually different types. There's clear cell, papillary, chromophobe. Clear cell is the most common, and then the hereditary ones have different. There's different hereditary ones and all sorts of ones that are less than 1% or very, very small percentage. But it it depends on the cells in which it arises, and there's different types. Part of our job as radiologists as well, and why imaging is so important, is the stage of renal cell carcinoma. So this is the TNM staging system, and this is the stage 1, 2, 3, 4, 3A, 3B, 4. So depending on the size of T is for tumor, depending on its size, N is for nodal status, and M is for metastatic disease. This is size and also involvement of other organs. So this is how the oncologists stage the lesion, and imaging tells you a lot of this information. And depending on what they see, that's how these are treated, or whether it's surgery or whether other things are needed prior to surgery, or just chemotherapy and radiation. So very, very important imaging. So what kind of imaging is used for renal cell carcinoma? Most common is CT, and in CT these are heterogeneous because these masses can have cystic areas of necrosis. They can actually have bleeding as well. So they look very heterogeneous, and you can get hemorrhage within it or around the kidney, which subcapsule means around the kidney, and some can contain calcification. So here's an example. Here's a CT scan that was done, and you can see this patient in the left kidney. So this is the patient cut kind of like a carrot. You cut a carrot. So this is a slice through the patient. That's the right kidney. This is the left kidney. This is a little bit of the liver, and this is all bowel. This is contrast that they drank in their small bowel. And you can see there's this mass in the left kidney, a large mass. This is a pre-contrast scan, and this is after they've given the contrast, the X-ray dye, which patients get most often when they're having these scans. And you can see that there's this enhancement or lighting up around it, and centrally there's necrosis in this mass. This is a coronal image, so kind of cut from top to bottom, and here's the mass as well. So you can see how well this imaging shows it. It shows the structures around it. There's the pancreas. The spleen is going to be up in here, and you can so you get the surgeons get a very good picture, and the oncologists as well, of what this looks like without doing any intervention whatsoever. Here's another example. Again, peripheral enhancement, or peripheral mean the outer part of this enhances, and centrally there's necrosis. And here's the coronal, and you can see the spleen is here. Here's the left kidney. Here's the right kidney, and there's the mass. Other things you can see, this was a clear cell carcinoma. This is in the right kidney. So again, this is an axial image cut like a carrot. The left kidney is not in the field of view here, but you can see there's a huge mass, and this is actually invading the renal vein. So that's important information for them to know as well. We can look at the vascular structures and see if there's invasion with imaging. And this is kind of an ill-defined tumor as well. You can see that it may be going into the fat next to the kidney, and that's important information for them to know. Here's an example of we talked about calcification. So this is a mass that didn't enhance a whole lot, but it had some calcification in it. It did enhance a little bit, and it's a papillary renal cell, one of the subtypes which don't tend to enhance quite as much. The other thing CT can be used for, and this depends on the preference of the radiologist, where the tumor is located, but often these will go for biopsy. So this is an example of a CT guided biopsy. There's a mass here. We don't see it very well because there's no X-ray dye. X-ray dye really tends to bring these things out. But the needle's going in, this is the edge of the needle, and a sample is being obtained. So ultrasound as well is used for renal cell carcinoma. And again, because these lesions, like I said, can be cystic, can have hemorrhage, proteinaceous debris, they can really be variable. So isoechoic means how it looks, in relation to the kidney, the remaining portion of the kidney. So iso means the same. Most are the same. Some are less, some are more, just depending on the size of the lesion and how heterogeneous it is. So here's an example. This is an ultrasound, the left kidney, and you can see there's the kidney right there. So that's the normal kidney. And this area that they're kind of measuring, these are the calipers to measure. This was 7 centimeters. This whole area right here is a big mass. And you can see that there's areas that are darker, areas that are brighter. There's this area that's really dark, and that may be partially red, but sometimes you get calcifications that make it appear dark. And again, ultrasound as well can be used for biopsy. So this is an example. This is the kidney here, the normal kidney right there. And there's a mass right here, you can see. It looks very similar to the kidney, the mass, but it's bulging out. And this is their needle going in. So you can see a needle going in and tissue being obtained from this mass. And then that's sent off and confirmed to be cancer, and it's treated based on what they find. So MRI as well. MRI is a very useful modality, and again, heterogeneous. So that's kind of a recurrent theme. For the clear cell, one of the subtypes, they tend to be hyper intense. They tend to be brighter, and the papillary tends to be hypo intense, a little darker. So that's helpful. Sometimes you can suggest which it may be, but it's not 100% predictive. So most often tissue will be obtained. And again, when you give contrast, T1C+, that means with contrast. And the contrast in MRI is called gadolinium. It's different than the iodine used in CT scan, and it gives you enhancement as well. So here are some examples with MRI. So again, similar picture to the CT. There's the liver, there's the spleen. This is the person cut top to bottom coronally. So we've kind of opened them up from top to bottom. Again, liver, spleen, and then this is the left kidney. And here's the right kidney. And on the right kidney, you can see this mass. And these areas right here are enhancement. You can see this thing is enhancing. So again, this mass here in the right kidney. Here's the vessel. Often you'll see if it's going into the vessel. This is the aorta. And obviously, other things. We look around lymph nodes, other sort of structures in there, the bones. So it's very useful. Again, here's another example. This is on the left side. So you can see here's the right kidney, the left kidney, and there's this big mass in the left kidney. This is coronal, and this is axial. We get multiple planes on MRI, which is helpful as well. So you get different. You get to look at it from top to bottom, and from the person kind of being cut like a carrot, imaging wise. So this is again enhancement around it, and then there's necrosis centrally. So renal cell carcinomas as well, they can be solid, but they can also be cystic, and renal cysts are very, very common. And the vast majority are benign. I mean, you see cysts virtually in every person that you scan over a certain age. Someone by the name of Bosniak from New York, he came up with a classification system. How do you know if these cysts are simple? Because occasionally they're not, and they can represent cancer within a cyst. So this is you may hear about the Bosniak classification. And the 1 is just a simple cyst, and the 4 is enhancing solid tissue with cystic component most commonly or without. And then there's levels in between. Sort of the breakup is here. Anything that's a 3 or more tends to go to surgery and gets resected. A 2F is a lesion that you follow. It doesn't fall neatly into category 2, which is just some thin septations or thin calcification within the cyst. With a 2F, maybe a little bit more complex, but not quite a 3 where you're seeing dense calcifications or lots of septations that appear thickened. So these, so this is a useful thing, and you may see it in reports and doctors talking about, a 2F lesion, which needs, usually we do a 6-month follow-up for that, or a 3 that needs surgical resection. And here's an example of a cystic lesion. This is a cyst in the kidney, but you can see that along the periphery of the cyst, there's these areas that are brighter, and they were enhancing. And here it is on the coronal. You can see that these bright areas of enhancement. So this was a cystic cancer, and this needed to be resected. Here's another example. Again, liver, right kidney, left kidney, and there's a cyst here in the left kidney. There's thin septations on this image, doesn't look terrible, but when you go a little bit lower, you can see that this septation here is a little thicker, nodular, and actually ultrasound was done on this patient as well. And what this box shows is color flow, so basically blood flow within the mass. And you can see that there's a little bit of blood. This septation is that septation right there on ultrasound, and there's actually flow within it. So the benign septations, the ones that are just simple, should not have flow in it, and this one does. So this ended up being a concerning lesion. It ended up being a renal cell carcinoma. This was taken out, a cystic renal cell carcinoma. So metastatic disease, another job that we have as radiologists, look for metastatic disease, because If there is metastatic disease, the treatment is very different. Taking out the tumor without dealing with metastasis is going to cause problems. You have to deal with both. So this was a large tumor in the left kidney. Here it is on the coronal image. You can see this large lesion here. But what you'll also notice, this is where the right adrenal gland sits, and there's a mass there as well. So this was a metastasis to the right adrenal gland. And when you look a little bit more in the liver, there's actually another area that's got a metastatic focus. So this is important information for the doctors to know, that this is not just within the kidney, but it's spread. So they need to treat it appropriately. We talked about von Hippel-Lindau disease, VHL. This is a renal cell carcinoma in that. In this disease, people get cysts in their pancreas. They can actually get tumors in the pancreas as well, cysts in the liver. So you see all these cystic areas in the pancreas here. And then there's these cysts in the kidneys, but some of these have enhancing areas within the cysts. So these were renal cell carcinomas within the kidney. And you can see the patient's left kidney had already been resected because of cancer on that side. Nowadays, renal cell carcinoma, as I discussed earlier, a lot are being found at very early stages, in very small sizes, 2 centimeters, 1 centimeter, 2.5 centimeters. So there's patients where they may not be good surgical candidates, or these things are so small that what we're doing nowadays, more and more, and now we're doing it, there's been data on this, that this is a very effective modality, is radiofrequency ablation. There's cryoablation as well. Radiofrequency ablation is basically heating the lesion and destroying the cancer cells that way. So here's a renal cell carcinoma, a needle is being put into it. These are the different types of radiofrequency devices that are used. And you heat it up and kill the cancer cells that way. So there's no surgery involved, and this is a day, you may stay overnight, some places stay overnight, but it's certainly a lot less invasive than having a surgery. It's just basically through the skin into the lesion using CAT scan guidance. And you ablate the lesion. Cryoablation is very similar as well. And this is an effective modality, especially for smaller lesions. And what they do after radiofrequency ablation is that they'll get CAT scans 3 months afterwards, and then 3 years. So you continue to go for CAT scans to make sure the tumor doesn't recur. And you can see this one. Afterwards, there's some scar tissue, and over 3 years. 3 years later, it's gotten smaller. And there's no cancer left at all. PET scan is another imaging modality that can be used for renal cell carcinoma. But for renal cell carcinoma, it's actually, it's quite limited for primary renal cell carcinoma. It only has a sensitivity of 62%. And the reason for that is FDG, which is the agent that's used for renal cell carcinoma, is excreted by the kidneys. So what happens is it accumulates in the kidneys, and it's therefore difficult to say whether there's a mass there or it's just accumulation, physiologic accumulation, as it's being excreted from the body. It is good though for recurrent cancer, PET scan, but CT remains the primary screening modality, just because often you're looking in the area of the kidney as well when you're looking for recurrence and that sort of thing. So CT scan is the most common modality, but PET scan can be used as well, looking for metastatic disease. So here's some examples. This is an MRI, a CAT scan, and you can see here's a PET scan, there's a mass there. So just to show you here, actually, you can see that this kidney is normal, but it's looking bright with the FDG. These are subtracted images. So you can see if this were a smaller area and central, you might miss it because you just think that it's normal excretion from the kidney. So this is why it's not a great modality for cancers within the kidney. Here's another example. This is a post-contrast and pre-contrast, and you can see the PET scan shows it nicely. And as I discussed, PET scan is very often used to assess for metastatic disease. So this is a PET scan. This is a coronal image. There's the brain, and then we're coming down liver, spleen. These are the lungs. Pelvis is down here, and you can see all these lymph nodes. So this cancer has metastasized to multiple lymph nodes. This is often now we do PET CT. So these are the CT images that accompany the PET, and it shows all these metastatic lymph nodes. So PET scan is very useful in this case. But CT, with contrast would have shown this as well. So both are options. So as far as follow-up for renal cell carcinoma, unfortunately, there's no consistent guidelines. This is the American College of Radiology guidelines, the Royal College, the European, and then literature review. This is from a radiology journal. So you can see there's no consistency. So often there's local sort of they're very similar, but there's no hard guidelines as to what the kind of follow-up should be. It depends on the stage, and it depends on the local preference, whether to use CT or PET or to use CT scan for chest X-rays. But the key is these are followed very carefully afterwards to look for recurrence. Okay, so just I'll talk a little bit. Just as I described, there's other types of renal cancer. So renal cell carcinoma is the most common, but other things are one type that's the second most common is a transitional cell carcinoma. So what that is it's a cancer of the collecting systems of the kidney. So the kidneys filter the blood and create urine, and then the urine goes into the renal pelvis and then down into the ureters and then into the bladder. So it's how it's transported from the kidney into the bladder. And you can get cancers within the collecting system as well, which is called the transitional cell carcinoma, just based on the cells that line these areas, which are different than the kidney. So transitional carcinoma is 7% of all renal neoplasms. It actually happens in the bladder much more commonly than in the kidneys and the ureters, but it can occur in both areas. And in fact, it can occur, when you do have bladder cancer, up to 30% will have metachronous, which means at the same time transitional cell carcinoma in 2 to 4 years. Or excuse me, 30% of upper tract will have metachronous TCC of the bladder in 2 to 4 years. So these people that get it in these areas can get it in the bladder. And the reason for that is the cancer cells can travel down into the bladder with the urine as urine is formed. And there's an increased risk from tobacco, toxins, and other sorts of things. And this presents usually with hematuria, which means blood in the urine, and pain in the kidney, in the back, in the kidney area. So intravenous IVP, which is an intravenous pyelogram, used to be used in the old days. And what that was X-ray dye was given. It went to the kidneys and then was excreted from the kidneys into the bladder, and X-rays were taken. And what you saw was filling defects in these areas, or hydronephrosis, swelling of the kidney because the kidney was blocked by these cancerous areas. So this is an example of an IVP. So X-ray dye has been given. This is the left renal pelvis. So this is the collecting part of the left kidney. It looks a little bit swollen. And then there's a catheter in the urine at this point, in the ureter at this point. This is the ureter. But you can see that there's this mass around the ureter here. So this is a filling defect. And here it is on CAT scan. You can see there's a big mass and filling defect around the ureter. There was a little bit of a filling defect here as well in the kidney. But this is sort of the older. We don't do very many of these anymore, these IVPs, because we have better tests now. We have better modalities now, such as CT and MRI. And ultrasound as well, if it's within the kidney. You see a hypoechoic mass, so a mass that's dark, similar to the kidney. And you can see some separation in the kidney and blockage and swelling of the kidney with it. So I'll just show you some examples. Well, actually, first we'll talk about CT. A key thing with CT, because this is excreted into the collecting system, which is it goes through the kidney. After the kidney filters it, it goes, as I said, it goes towards the bladder. It's important to do delayed films. So what you'll notice if you're ever getting a CAT scan for one of these is they'll do a scan prior to giving you X-ray dye. Then they'll do another scan or 2 scans after the X-ray dye has been given very soon afterwards. And often you'll lay on the table for 5 or 10 minutes and they'll do another scan. And that delayed one is to allow time for the contrast to enter the collecting system. So come out of the kidney and go into the collecting system on its way to the bladder to see if there's any abnormalities there. And for this, it's very important to do it because you're going to see an opacification. You're going to see a filling defect in an opacified collecting system. And I'll show you examples here. You can get invasion into the kidney, and the tumor itself can enhance with the X-ray dye as well. So here's an example. This is a patient that actually had a bladder cancer that was removed, and ileal conduit was formed, and this person had a recurrence. Here you can see in the left renal pelvis, there's this mass-like area, and also this is the ureter, and around the ureter there was a mass as well. And what we did also with this person is something called a lupogram. So what that is a catheter is put into the ileal conduit. And for those of you that may not know it, what an ileal conduit is once the bladder is removed, a piece of small bowel is taken and connected to the skin. The ureters, which drain from the kidney to the bladder, are attached to this area, and then this drains to the skin, allows urine to come out through the skin. There's other surgeries that can be occasionally done as well, where a new bladder is created, but this is often done. So what we've done here is we put a catheter into the area where this small bowel loop connects to the skin, and we inject X-ray dye to see how this looks, and the X-ray dye will go back up into the kidneys as well. So what you can see is, here's the ureter. This is the kidney, the collecting system, and as the ureter comes down, you can see there's a filling defect here, which corresponds to that abnormality that we saw on CT scan. So this was a recurrence in the ureter. Here's another example of a transitional cell carcinoma. You can see there's a mass here in the left renal pelvis, and these are the delayed scans. You can see how well you see this mass. The contrast now has gone from the kidney into the collecting system, and you can see that there's it shows it really, really nicely. The filling defect, transitional carcinoma. Renal lymphoma, I'll briefly touch on that. That's about 3 to 6% of renal cancers that we see on imaging. Most often, this is in people who have lymphoma in other parts of the body, and it develops in the kidney. And whether they have non-Hodgkin's lymphoma, this is usually late in the disease, or Hodgkin's, you can get some renal involvement as well. Primary renal cell carcinoma is rarer, is much rarer, but you can get primary. In other words, it starts in the kidney. That can happen as well, and it can spread throughout the blood. It can be in one area, or diffuse infiltration of the kidney, or you can get renal cell carcinoma coming from an adjacent organ, and I'll show you examples of these quickly. And it can be either on one side, which is unilateral, or bilateral. It's most often on one side. So ultrasound for these, just to show you what it looks like, you can get single or multiple anechoic. So anechoic means very dark, or hypoechoic. Lymphoma tends to be dark. That's kind of a characteristic of it, and that helps us as well as radiologists. If someone has lymphoma and we see something like this in the kidney, it kind of alerts us that this may, that's what may be going on. And you can see an enlargement, a big kidney, and other sorts of signs. On CT, this is CE-CT, is contrast enhanced CT. You can see poorly marginated mass that are less dense than the kidney. These don't tend to enhance a whole lot, these lymphomas. So again, that's a clue for us that that's what could be going on. Here's an example of a primary renal lymphoma. As I said, it's very rare for lymphoma not to be elsewhere in the body and start out in the kidney. So this is the right kidney, this is the left kidney, and you can see this area around the kidney, this large area kind of enveloping the kidney, and that ended up being lymphoma. And this is actually a characteristic look for renal lymphoma. It sort of envelops the kidney. So if we see this pattern, we suggest that this could be lymphoma, and this would go on to biopsy through the skin. We would put a needle and get some tissue to confirm that. Here's another example of renal lymphoma. You can see this area, this dark area in the kidney. This is the left kidney and the right kidney. And you can see part of the right kidney is enhancing normally with the X-ray dye. The left kidney enhances, and this area is darker. So this is where the mass is. This is a nuclear medicine scan showing the mass as well. And you can see there's also actually in this case some bony involvement. You can see how that bone, this is the pelvis, and you can see there's dark areas in the pelvis. So that was from lymphoma as well. This is an example of someone who has a large mass in their, it's called the retroperitoneum, which is the back part of the abdomen. And you can see it's compressing the vessel and it's invading both kidneys. It's a big mass just kind of invading all around. This is the spine here, and the mass is going around the spine as well. This was the same area on ultrasound. So this is the mass, and this is the kidney, and it's making its way into it, as well as over here you can see this is a sagittal image. So that's kind of a whirlwind tour. There's lots of other renal lesions and masses, but these are the most common ones. So hopefully that gives you an idea of what we look for as radiologists and what kind of things we're seeing. So I'm happy to discuss or answer questions if there are any.
Awesome. Thank you so much, Doctor. I learned a lot too from this. If anyone does have any questions, feel free to type them out into the chat box, and we'll be happy to get those answered here. And there's a chance that most of our questions will come in via email or through social media in the future. So I appreciate you providing your email address. And if anyone asks any questions on our social media pages, we'll be sure to relay that to you as well.
Yeah. Great. Yeah, and feel free to email me anytime, and I'm happy to answer any questions. I can put my email back up. Go to the first slide here. Whoops. Just go back to the beginning, and that'll just show everyone my email. Here it is here. So if anybody has any questions, go ahead and feel free.
Thank you so much, Doctor. I appreciate your time today, and thank you for those who attended. If you missed any part of this recording, we will be putting it on our website, and it is on our Facebook right now. So feel free to check it out. Thank you so much, Doctor. You have a great day.
Okay, thank you. Appreciate it.